Thank you, Candy. Fever, malaise, that's fatigue, mouth ulcer, sore throat. Those are symptoms of agranulocytosis. Okay, and agranulocytosis is common to sulfasalazine. So let's quickly recap. What other medications can you think of that causes blood dyscrasias? What other medications cause blood dyscrasias? Methotrexate, okay. Which other one? What CNS group of medications cause blood dyscrasias? Anti-epileptics, thank you, Treasure. So Queen said phenytoin as well. So many anti-epileptics like clozapine and olanzapine actually cause blood dyscrasias. That's correct. Which other class of medication causes blood dyscrasias? Clozapine, that's a CNS medication as well. Carbimazole, yes, carbimazole, linezolid. Okay, all these medications cause blood dyscrasias, DMARDs as well. Well done, everyone. So my next question is this: sulfasalazine causes urine discoloration. That's true. What color of urine do we expect? What urine discoloration do we expect with sulfasalazine? Orange-ish, reddish orange. Okay, reddish orange, or generally orange. Orange is the most common that you would see. Okay, so what antibiotic also causes urine discoloration? What antibiotic causes urine discoloration? So Presh said rifampicin, that's correct for tuberculosis. Nitrofurantoin, that's correct. Nitrofurantoin also causes urine discoloration. What medication used for Parkinson's disease also causes urine to be discolored? Used for Parkinson's disease, levodopa and entacapone. Well done, well done. You guys are doing great. Levodopa and entacapone. What medication used for constipation also causes urine discoloration? Senna. Yes. Senna is correct. Senna also causes urine discoloration. Aside Senna, which other one? Which other medication for constipation discolors urine? Codantrama. Yes, codantrama is correct. All right, let's quickly recap. Sulfasalazine, what are the common indications for sulfasalazine? Is it just ulcerative colitis? Is it only ulcerative colitis? Can sulfasalazine also be used for Crohn's disease? Yeah, generally it's used for inflammatory bowel disease, okay? Both Crohn's and ulcerative colitis. Sulfasalazine is first line for Crohn's disease. Is that true or false? Let's quickly recap on management of Crohn's disease. Sulfasalazine is first line for Crohn's disease. Is that true or false? False. So what's first line for Crohn's disease? Corticosteroids. Yes, well done. Well done. Sulfasalazine is not first line for Crohn's disease. And the way you can remember it is C for Crohn's disease, C for corticosteroids. So corticosteroids are actually first line for Crohn's disease, not sulfasalazine. Okay, as a matter of fact, sulfasalazine works majorly on the colon. Okay, the active form of the medication is released in the colon, so it's more suitable for ulcerative colitis. So Crohn's disease, corticosteroids as first line. Okay, so if a patient has more than one remission in a year, right, what add-on medication can we give to help induce remission in patients with Crohn's disease? If a patient has more than one flare up, if the patient has more than one flare up of Crohn's disease, what's add-on medication? Azathioprine. Aside azathioprine, methotrexate as well. That's correct. Okay. Remember that corticosteroids are not used. Corticosteroids can be used for maintaining remission in Crohn's disease. Is that true or false? Yes. Corticosteroids cannot be used for maintaining remission, and the way to remember it is because corticosteroids shouldn't really be used long term, and that's because of the side effects of corticosteroids. So they are majorly used for inducing remission, they are not used for maintenance of remission. So remember that if a patient has more than one episode, then add-on treatments can be used, such as azathioprine, mercaptopurine, or methotrexate. Okay, if the patient has greater than or equal to two exacerbations in 12 months. What's the advice regarding fluid intake and sulfasalazine? Does anyone know? What's the advice regarding fluid intake and sulfasalazine? Patients should reduce their fluid intake while on sulfasalazine. Is that true or false? False, yes. Adequate fluid intake is recommended. Okay, adequate fluid intake is recommended with sulfasalazine, and that's because it can cause crystalluria, it can cause crystal formation, yes, like Presh said, in the urine. So adequate fluid intake is recommended in patients on sulfasalazine. Sulfasalazine can cause glucose 6 phosphate deficiency, G6PD deficiency. Is that true or false? True. Yes, that's one point you should remember. Okay, it can cause G6PD deficiency. What other medications can cause G6PD deficiency aside sulfasalazine? Yes, nitrofurantoin. Thanks, Moy. Thanks, Joy. Thanks, Presh. Nitrofurantoin. Uchenna said primaquine. Okay, that's correct. Primaquine is also correct. Nitrofurantoin, yes. Antiepileptics. Some of them, dapsone as well, sulfonamides. These medications can cause glucose 6 phosphate deficiency. So we mentioned that adequate fluid intake is required in patients on sulfasalazine. What other medications require adequate fluid intake? What other medications require adequate fluid intake? Pancreatine, okay. Alendronic acid, that's because of the risk of esophageal irritation. What antibiotic requires that the patient takes a full glass of water? Yes, Joy has mentioned that doxycycline. Okay, doxycycline requires that the patient takes a full glass of water, and that's because it can cause esophageal irritation. So doxycycline is correct. Which other medication? Which medication for constipation? Which laxative requires adequate fluid intake, and why? Which laxative requires adequate fluid intake and why? Common one. Bulk Yes, bulk is correct. It's Pagula, brand name Fibogel. So we always advise patients to maintain adequate fluid intake with Fibogel. And why? What's the reason? Why do we need patients to take adequate fluid with Fibogel with bulk laxatives? Does anyone know? Yes, because of the risk of intestinal obstruction. Thanks, Moe. Because of the risk of intestinal obstruction. With regards bulk laxatives, what time of the day do we advise patients to take it? Is it in the morning or at night? Do we advise them to, when shouldn't they take it? They should avoid it when? Yes, it should be avoided at bedtime. Bulk laxatives should be avoided at bedtime. Okay, so we revised medications that require adequate. Which medication for gout can also requires adequate fluid intake? Which medication for gout? Which medication for gout also requires adequate fluid intake? Yeah, so Minnie said allopurinol. That's correct. Well done, everyone. Allopurinol requires adequate fluid intake. Allopurinol should be taken on an empty stomach. Is that true or false? Is it taken with food or on an empty stomach? Allopurinol is taken with food. Yes, it's best taken after food. Then there is a medication as well that can cause hemorrhagic cystitis. It's a chemotherapy medication and it requires adequate fluid intake. What medication is that? What medication is that requires, yes, well done, Ada, well done, Joy, cyclophosphamide. Cyclophosphamide can cause hemorrhagic cystitis, right? It's a chemotherapy medication and requires adequate fluid intake as well. So that's important. Okay, so I'm going to move to the next question now. Which of the following medicine is most likely responsible for increasing this patient's blood glucose level? So I've got a couple of prednisolones. Okay. Well done, well done, well done, everyone. So steroids can cause hyperglycemia. Okay, steroids can cause hyperglycemia. The patient has hyperglycemia despite not having any medication. So the culprit is most likely the prednisolone. Prednisolone can cause hyperglycemia. So let's quickly recap on other side effects of prednisolone. With regards electrolyte disturbances, prednisolone would cause low sodium levels. Is that true or false? Prednisolone will cause low sodium levels. Is that true or false? It's false. Okay, steroids cause hypernatremia. Okay, remember that steroids can cause a patient's blood pressure to go up, and that's because of the high sodium in glycosis. So steroids can cause hypernatremia. Okay, steroids can cause hypernatremia. That's important. What about potassium? What's the effect of steroids on potassium level? Is it hyperkalemia or hypokalemia? Hypokalemia. So steroids can cause elevated sodium and it can cause hypokalemia, low potassium levels. Okay. Steroids can cause weight loss. Is that true or false? What's the effect of steroids on the weight? Steroids cause weight gain. Yes, they definitely cause weight gain. They cause hypernatremia. They cause weight gain. Other side effects of steroids. Can you list the one you can remember? What are the other side effects of steroids? Osteoporosis, very important. Cushing syndrome, edema. Well done, everyone. What are the other side effects of steroids that you can remember? Psychiatric reactions, yes. Steroids should be taken after food. Is that true or false? Steroids are best taken after food. That's because they can cause irritation to the stomach. So they are best taken after food. That's very important as well. Are these to be taken in the morning or at night? When would you advise patients to take steroids in the morning? Why? Why do we advise patients to take steroids in the morning? Because of insomnia. Yes, they can cause sleep disturbances. They can cause psychiatric reactions. They can cause sleep disturbances. So it's best taken in the morning and it's best taken after food. All right. So what other medications comes to mind that can cause hyperglycemia aside steroids? Examples of other medications that can cause high blood glucose levels. Uppressed clozapine, okay? Miniset statin, that's correct. Beta blockers, antipsychotics. Okay, which other one? What antihypertensive can cause hyperglycemia? Yes, Rukayat has mentioned it already. Thiazide diuretics. Thiazide diuretics can cause hyperglycemia. So, what two antipsychotics are most likely to cause elevated sugar level? What two antipsychotics are most likely to cause elevated sugar level? Clozapine and olanzapine. Yes, clozapine and olanzapine. Okay, are most likely to cause, I think, cheese and onions. That's the way some people remember it, cheese and onion. They are most likely to cause elevated sugar levels. Okay, so is there anyone? We've mentioned thiazide diuretics, we've mentioned steroids, even statins as well can also cause elevated sugar level. So, which medication on my list requires brand prescribing? Out of A, B, C, D, and E, which of them should be prescribed by brand? Option E should be prescribed by brand. That's correct. Okay, option E should be prescribed by brand. And Why do we need to, why does it need, what class of medication is it? Why does it need to be prescribed by brand? In case someone doesn't know, it's a biologic, yes. So biologics generally should be prescribed by brand. Don't forget, biologics generally should be prescribed by brand. So what are the other examples of biologics that you remember aside this one? Joy said adalimumab. Yes, adalimumab. That's a biologic medicine. Infliximab. Thank you, Minnie. Yes, thank you, Kendi. Adalimumab. Thanks, Uchina. These are examples. So medications that ends with mab, like Treasure mentioned, adalimumab, infliximab, or malizumab. Those are examples of biologics. Okay, we've also got etanercept as well. It's also a biologic medicine. Okay, so which medication for bipolar disorder should also be prescribed by brand? Which medication for, yes, lithium. Lithium requires brand prescribing as well. Lithium requires brand prescribing. Which medication for organ transplant rejection? Which immunotherapy medication, immunosuppressants, requires brand prescribing as well? So Moa said tacrolimus. Well done for me. Tacrolimus. Aside tacrolimus, which other one? Cyclosporine. Yes, cyclosporine should be prescribed by brand. Tacrolimus should be prescribed by brand. Biologics should be prescribed by brand. What are the anti-epileptics that require brand prescribing? Can you list all of them? The anti-epileptics that require CP3. Okay, CP3. So carbamazepine, phenytoin, phenobarbital, and primidone. Well done, Minnie. CP3. These are examples of medications that would require brand prescribing. Okay. So the next question is, which medication on my list would cause pulmonary toxicity and liver toxicity and also phototoxicity? Out of options A, B, C, D, and E, which of them would cause pulmonary toxicity, liver toxicity, and phototoxicity? Methotrexate, yes. So remember, methotrexate could affect the lungs. Methotrexate could also affect the liver. Okay, methotrexate could affect the lungs. Methotrexate could also affect the liver. I think then we had a mnemonic blood G, bone marrow toxicity, liver toxicity. It can also cause phototoxicity, that's UV radiation, respiratory toxicity, and what other toxicity can it cause? If the patient presents with diarrhea, for example, yes, Prested gastrointestinal toxicity. That's important for methotrexate. Okay, so if, for example, the patient presents with dry cough or difficulty breathing, it could be due to toxicity, methotrexate induced pneumonitis. Okay, U is for UV radiation. It's just a way to remember. It's just a way to remember phototoxicity with methotrexate. I'm going to type it now on the screen. Blood G. So B for bone marrow toxicity, L for liver toxicity, U for UV radiation, R for respiratory toxicity, and G for gastrointestinal toxicity. And how do we treat gastrointestinal toxicity with methotrexate? What do we use to help? Not methotrexate toxicity, just the GI side effects now, not overdose of methotrexate, because it's different. So what do we use to manage the gastrointestinal side effects of methotrexate? Folic acid, yes, thank you, Kendi. Folic acid is used for that. Folinic acid is used for overdose with methotrexate. Okay. So which other medication used for atrial fibrillation can also cause respiratory toxicity, just like methotrexate? So for me, B is for bone marrow toxicity, L is for liver toxicity, U is for UV radiation, that's phototoxicity, R is for respiratory toxicity, and G is for gastrointestinal toxicity. I'm going to upload the video on YouTube so you can always go back if you missed anything. Yes, amiodarone can cause phototoxicity as well. Okay. If the patient presents with elevated alanine transferase and aspartate transferase as well, ALT and AST. If the patient presents with elevated ALT and AST, which medication could be the reason? On my list now, the medications on my list, which medication could be the cause? Methotrexate, yeah, that's because methotrexate causes liver toxicity. Remember I said blood G. L for liver toxicity. And the symptoms of liver the enzymes that could get elevated in patients with liver toxicity are ALT and AST. Okay. So we said methotrexate could also cause phototoxicity. Which other medication causes phototoxicity aside methotrexate? What antibiotic? Tetracycline. Well done. Doxycycline. What else? What medication for atrial fibrillation could also cause phototoxicity? Amiodarone, yes. Isotretinoin, yes, is correct as well. Isotretinoin is correct. And for this question, the last thing I'm going to ask is the safety in pregnancy of methotrexate. What's the how long the patient need to use contraception for? 6 months. Is that for both men and women? So patients should continue contraception for at least 6 months after stopping methotrexate. That's for women, while men taking methotrexate should avoid contraception during treatment and for 3 months after stopping. Okay. So remember that sulfasalazine can cause blood dyscrasia. Symptoms of blood dyscrasias are fatigue, mouth ulcers. Okay, symptoms of blood dyscrasias are fatigue and mouth ulcers and easy bruising and bleeding as well. And we said sulfasalazine requires adequate fluid intake as well. We said it's used for management of inflammatory bowel disease, and we mentioned how Crohn's disease, first line for Crohn's disease is corticosteroids. And the way to remember that is C for Crohn's disease, C for corticosteroids. Sulfasalazine is an amino salicylate and it can be used for ulcerative colitis as well. All right, so let's move to the next question. Patient has been diagnosed with a C. difficile infection. Which of the following is the most appropriate first line initial treatment? Yeah, so everyone is going for vancomycin. That's correct, okay? For an initial episode of C. difficile infection, vancomycin is recommended as first line. What second line? Fidaxomicin, yes, that's correct. So first line is vancomycin, second line is fidaxomicin. Okay, first line is vancomycin. Previously, metronidazole was used initially for C. difficile infection, but recent guideline says that vancomycin should be used first and fidaxomicin should be used as second line. What antibiotics cause C. difficile? There are four C's. That's a good way to remember it. Four C's. Antibiotics that commonly cause Clostridium difficile infection. Clindamycin, cephalosporin. I think Mini has listed all four, which is correct. Clindamycin, cephalosporins, broad spectrum penicillins. What else? Coamoxiclav and ciprofloxacin. Okay, ciprofloxacin. So when you remember ciprofloxacin, fluoroquinolones in general, not just ciprofloxacin, but fluoroquinolones in general can cause C. difficile. So if a patient presents with diarrhea while on amoxicillin or coamoxiclav, yes, penicillin, broad spectrum penicillins can also cause C. difficile infection. If a patient presents with diarrhea while on amoxicillin or coamoxiclav, would you refer the patient or would you tell them it's a normal side effect? If the patient is on amoxicillin or coamoxiclav and the patient presents with diarrhea. Amoxicillin now. Amoxicillin and diarrhea. What antibiotic has the highest risk of causing C. difficile infection? Clindamycin, yes, that's what I was looking for, okay? So if a patient on clindamycin presents with diarrhea, then we need to refer them urgently. But with amoxicillin, it's a side effect, okay? Amoxicillin is a normal side effect of amoxicillin. Diarrhea is a normal side effect of amoxicillin. It's a common side effect. However, with clindamycin, then we need to refer them because clindamycin has the highest risk of causing a C. difficile infection. So which of these medications, if the patient presents with flushing, rash, itchy skin, okay, which of these medications could be the culprits? Flushing, rash, hypotension, and pruritus. Which of these medications could be the cause? Flushing, rash, hypotension, and pruritus. Which of these medications could be the cause? Vancomycin, yes. And what condition? What condition will come to mind? Redman syndrome, yes. Vancomycin can cause Redman syndrome. Examples, symptoms of Redman syndrome includes flushing, rash, hypotension, and pruritus. It's usually caused by rapid IV infusion. So we advise that for management, the infusion should be given slowly, and antihistamines can be used as well. A patient presents with pain in the tendon. Which of these medications could be the cause? If the patient presents with pain in the tendon, yes, levofloxacin can cause Achilles tendon pain. So fluoroquinolones generally can cause tendonitis. So patients should stop the medication immediately if they present with that symptom. If the patient has elevated alkaline phosphatase and elevated bilirubin, which of these medication could be the cause? Which of these medications could be the cause? Coamoxiclav, that's correct. Okay, coamoxiclav can cause high can what condition? What condition? Cholestatic jaundice. Yes, coamoxiclav can cause cholestatic jaundice and would expect elevated ALP and elevated bilirubin with cholestatic jaundice. Okay, well done everyone. My next question is which of these medications can be used for high severity CAP? Which of these medications can be used for high severity community acquired pneumonia? So is it A or is I've got some people said A, some people said C. Okay, let's quickly recap. For community acquired pneumonia, if it's severe, okay, if it's really severe, then we can give coamoxiclav. But is it going to be coamoxiclav alone? Is it coamoxiclav alone? Yes, just like Precious has said, IV coamoxiclav plus clarithromycin, that's the treatment strategy for severe community-acquired pneumonia. Okay, IV coamoxiclav plus clarithromycin. Another option is levofloxacin as well, given intravenously. So IV levofloxacin. So if the community-acquired pneumonia is severe, the first line option is IV coamoxiclav in combination with clarithromycin, and the second option is IV levofloxacin. Okay, what if it's just a mild community acquired pneumonia? What's the treatment option for mild CAP? If it's just mild, the first line is amoxicillin. So if you get a question, the patient has a mild community acquired pneumonia, the answer is amoxicillin. But what if the patient has penicillin allergy? If the patient is allergic to penicillin, what are the other options if the patient is allergic to penicillin? Doxycycline, or erythromycin or clarithromycin. So generally, if the patient is allergic to penicillin, the treatment options would be a macrolide, okay, a macrolide or doxycycline, okay, macrolide or doxycycline, which is suitable in pregnancy, which is more suitable in pregnancy. Erythromycin, yes, erythromycin is more suitable in pregnancy. So just remember that if it's just a mild community acquired pneumonia, amoxicillin can do the job. Okay, just regular amoxicillin can do the job if it's mild. Okay, however, if the patient has got allergic to penicillin, then the other options are doxycycline or a macrolide. That's doxycycline, clarithromycin, or erythromycin. So C, D, E. C for clarithromycin, D for doxycycline, and E for erythromycin. Those are the options for patients who have got penicillin allergy for the management of mild community acquired pneumonia. And we said if it's severe, they will need intravenous medication, IV coamoxiclav in combination with clarithromycin or IV levofloxacin. So we mentioned that vancomycin can cause red man syndrome. What other common symptom is associated with vancomycin? What other common symptom side effects with vancomycin? What other common side effect is associated with vancomycin? Yes, vancomycin can cause ototoxicity and nephrotoxicity. Okay, vancomycin can cause ototoxicity and nephrotoxicity. Examples of other medications that can cause ototoxicity. Can you give me an antihypertensive medication that can cause ototoxicity aside? What antihypertensive? Loop diuretics, that's correct. Well done, Presh. Well done, Rukayat. Well done, Ada. Yes, loop diuretics can cause ototoxicity. Loop diuretics can cause ototoxicity. Which chemotherapy medication can cause ototoxicity? Which chemotherapy medication can cause ototoxicity? Starts with letter C. Yes, Olu has mentioned it correctly. Cisplatin. Cisplatin can cause ototoxicity. So we've learned cisplatin, we've learned loop diuretics, we've learned vancomycin, okay, aminoglycosides. Vancomycin can also cause ototoxicity. We've learned the four C's of C. difficile, clindamycin, cephalosporins, coamoxiclav, and ciprofloxacin. Okay. I'm going to put up the last question now for today. Miss C is a 32-year-old woman who presents at your pharmacy with a prescription for doxycycline. Which of the following is the most appropriate label for the medication? So I've got a couple of option B, that's correct. Well done. Well done. Option B is correct. So can someone tell me why is option C not the correct answer? Why is option C not the correct answer? Doxycycline can be taken with milk. Yes, thank you. Thanks to that person that answered. Yeah, so doxycycline, it's not part of the cautionary label for doxycycline. Okay, for the milk part. So the way to remember it is doxy likes milk. D for doxycycline, L for limecycline, and M for minocycline. Those three medications can be taken with milk. Okay, they can be taken with milk. So option C is wrong. And option A says avoid alcohol. What antibiotic do we avoid? Do we advise patients to avoid alcohol with? Metronidazole? Yes. So how long do they need to avoid alcohol with metronidazole? 48 hours. Yes. So patients should avoid alcohol after taking metronidazole for 48 hours. And that's because of the side effects. What side effects? Disulfiram-like reactions. Yes, that is because it can cause disulfiram-like reactions. So option B is the most appropriate answer. Okay, it should be taken with a full glass of water like we discussed earlier because it can cause esophageal irritations, and doxycycline is phototoxic as well. So what other medications are phototoxic? What other antibiotics now are phototoxic? aside doxycycline. Demeclocycline, tetracyclines in general. Okay, limecycline is phototoxic, doxycycline is phototoxic. Okay, which other medication? Which other antibiotics? Yes, methotrexate is phototoxic as well. Cipro, yes, thank you, meaning that's what I was looking for. Quinolones generally are phototoxic, so ciprofloxacin is also phototoxic. So doxycyclines, tetracyclines, ciprofloxacin, quinolones generally are phototoxic. Okay, those are examples of phototoxic antibiotics. We also revise methotrexate, amiodarone, like Ada has mentioned, as examples of phototoxic medications. Even isotretinoin as well is phototoxic. What's the very common indication of doxycycline? Doxycycline, what indications? Where would you see doxycycline used? Malaria, okay. What else? Chlamydia, yes, doxycycline can be used for chlamydia. What respiratory infection comes to mind? COPD exacerbation. What's the dose for doxycycline for COPD exacerbation? Used for CAP as well. What's the dose of doxycycline for COPD exacerbation? So usually it's given as 200 milligram starts, then 100 milligram once daily. Okay, 200 milligram starts, then 100 milligram once daily. Okay, so well done everyone. We're going to stop the session here and we'll continue on Saturday. On Saturday, we're going to do a quiz just like we did it last Saturday, and the quiz would cover some of the things we've discussed here. Okay, on that note, I would